Hi, everybody. Welcome to our 8 o'clock show. There are two things that are interesting today. One of the things with this lockdown is a lot of us are binge watching, and I'm sure some of you are seeing things like Grey's Anatomy and shows like that. And so it's sort of, what does it mean to be a doctor in times like this? On one hand, it's a profession that's at the cutting edge of saving lives, and it's also at the cutting edge of risking your life. Both happen in this profession. So our guest today is, I'm going to spend a little bit of time having him talk about himself, because it's very rare to find people like this who have such different backgrounds and different interests. And I have known Dr. Akash Goel for over a decade, since he was a student, and it's been amazing for me to see his his growth and how much he has done. And by the way, as we are going through this, if you have questions, please pose them, because we are having somebody who's really fighting from the front lines from New York. So if you have any questions, pose them. So our speaker today is Dr. Akash Goel. Number one, he's a doctor. He's an assistant professor of medicine at New York Presbyterian Hospital and Weill Cornell and all that stuff. But he also writes. His work has been published in many magazines, and he shows, CNN, New York Times, Time Magazine, Financial Times, BBC. He's a prolific writer. And he also has a couple of Cannes Lions, and he also is recognized by United Nations for his work in human rights advocacy. So here is somebody who's practicing medicine, who is treating people, who is in public health, who is a writer, and a very creative personality. So I'd love for you to ask him questions and make it as interactive as possible. So in a minute, let's bring Dr. Akash Goel from New York. Okay, there. Hey, Akash.
Hi, how are you? Thanks so much. It's nice to see you.
Yeah, the last time we met at a very different circumstance. We were in a Anita Dongre store in New York at a dinner party, and now the world has changed since then.
That's right.
And I've been reading a lot of stuff. You've been co-authoring, you've been authoring, etc. So, one of the things, as I was saying in your introduction, Akash, you do many, many things. You write, you treat, you're in public health. But tell me, what did you get your Cannes Lions for?
Yeah, so that was actually a project that we launched in Pakistan in 2014. It was called Not a Bug Splat, and it was around the drone warfare that was sort of, very significant in kind of the early 2000s. And also there were significant kind of civilian casualties and a lot of trauma, in Western Pakistan. And so we were trying to raise awareness around that issue. And so, rather than kind of the sort of just chatter, we wanted to humanize the issue through artwork. So we installed a stadium-sized photograph of a child, whose family was affected by the bombings. And this was like 100 by 100 feet. It was the size of a stadium in KP in Western Pakistan. And the idea was that we were speaking to the drone operators directly. So when they would fly over, they would see, the actual face of a child rather than just a landscape. And so we actually leaked that photograph to the Express Tribune in, at that time, it was, sort of March, April of 2014. And it went viral. It reached about 3.5 billion media impressions. And it was really covered by every major media outlet. And really, since then, really in the year after that, there was a precipitous decline in drone campaigns, including loss of civilian, of casualties. So we think it was a very powerful project. And
so when you say we, who all worked on it?
So I work kind of with an artist collective. There are a couple of creative directors in advertising, for BBDO, as well as a couple of ad agencies. And then we actually launched that. There were four of us, and one of them was JR, who's, sort
Right,
of
of course.
recognized. So it was sort of a JR Inside Out project where he, engages citizens to participate in art activism. So it was a part of that. We've, we've stayed friends with JR and his group, and so actually talking to them about doing some work around, the global pandemic as well, and this time kind of focused on how we can show solidarity and support towards healthcare workers. Which is something I've been passionate about.
So, one of the things is, Akash, first of all, to do medicine itself is a many years journey. There's medicine, and tell us a little bit about what's your specialty. What all did you study?
Yeah, so my field is gastroenterology, and I focus on nutrition and digestive health. Really it's sort of my early interest in it came because, my parents are Indian. I'm first generation. My father's from rural India, Punjab, and he actually grew up as a sugarcane and soybean farmer. And, growing up and visiting his village, I would realize that there were lots of fundamental bottlenecks to distribution to last mile communities for essential medications, things like antibiotics, oral rehydration salts, zinc, vitamin A, things like that. But, you could get things like Coca-Cola and cell phones. And so, I sort of was really interested in kind of big food and beverage companies and how they were very kind of penetrated in last mile communities. And, years later, my family immigrated to the US. I grew up in the middle of Illinois, and, the middle of most of the country is farmland. And so I grew up around kind of cornfields and soybean fields, and you sort of realize that the system is actually kind of quite a destructive system. In the Midwest, about 45% of the agricultural crop, speaking of corn, goes to livestock feed. About 35% goes to biofuels, and then about 15% goes to manufacturing, mostly for high fructose corn syrup. So less than 10% goes to the kind of supply chain for food. And so I've been always kind of really interested, kind of growing up with this legacy of agriculture and farming. I just had always had an interest in food as a driver of health, and disease prevention. And so I really focus on that, not only on human health, but also in planetary health. So now, we're seeing that, we've long known that nutrition is the number one driver of death and disease, but what we're also seeing is that it's really the number one driver of environmental change. Now we're in the Anthropocene, which is kind of a geologic epoch, in which human activity constitutes the largest driver of, environmental change. And of that, we think the food sector is really the number one driver. And so I'm working to kind of connect the dots between human and planetary health through food and nutrition.
And I think there are two things for nutrition. One is the effect it has on the land, the types of crops you grow, the types of things you grow, effect it has on the land and environment, and it effect has on ourselves also. So because it directly goes into us, unlike cosmetics or something that are outside. So I think it's a very, very important field. To bring you a little, and another thing I have to say is that I think your parents' story is an amazing story of coming as migrants, and your sister is a very accomplished lawyer, you're a very accomplished doctor, and it's sort of to not just have kids but who are really, really excel at what they do. It says a lot about them also. So
yeah, thank you. Thank you.
And so, one of the things I wanted to talk, Akash, about, you've been writing a lot about being in New York. You've been writing
Yeah.
a lot about COVID. So it's the epicenter. I mean, the numbers are the highest in New York today. So what do you, just give us a little bit of, what's going on there, and what are you specifically involved in?
Yeah, I mean, so there's a lot to say about it. I mean, I think, just to kind of paint a picture, there's a huge dichotomy between, what New York kind of looks and feels like outside the hospital and what it looks and feels like inside the hospital. So, outside the hospital, it's pretty desolate. It kind of has, a little bit of an eerie feeling because, New York is the city that never sleeps, but it's kind of completely deserted, which is just kind of a little eerie to see. Inside the hospital, it's another story. We're initially preparing for pretty drastic, kind of numbers in terms of capacity. And so, the state projections initially were that, we were going to have to plan for about 140,000 beds and potentially 40,000 ICU beds. Well, the state prior to this had about 3,000 ICU beds. And, by the way, the United States has the highest number of ICU beds per capita of Western countries, even though they don't have the highest number of hospital beds. And so, we've been drastically kind of building capacity, for this surge. But, in sort of mid March, the numbers started to rise, and we've had huge demand, and so we've had hospital surges. So the governor has requested that every hospital increase capacity by at least 50%. So we've been building additional capacity, field hospitals. We've been changing behavioral health units, to med surg.
You converted the Jacob Javits Center also into a space where you can treat people. What have they converted it into? The Javits Center?
Yeah, so the Javits Center is actually hospital space. They have 1,000 beds there. Initially, it was supposed to be kind of for non-COVID care, to make room for hospitals to care for COVID patients. As you may know, we obviously cohort the patients together, as disease, as infection prevention and control.
Right.
So,
right, yeah.
So they changed that. The governor requested the president to allow to treat COVID patients there just because that's where most of the need is. So just to give you an example, I'm at New York Presbyterian, which is one of the largest health systems here in kind of the metropolitan New York area. We have about 4,000 hospital beds, not accounting for the surge. And, we have somewhere in the range of 2,500 patients with COVID, and about 20 to 25% of those are requiring ICU and ventilation. And so, there's significant demands on the emergency rooms, on the ICUs, on the medical staff. It's obviously, quite a hectic situation. I mean, I would say a few things. Number one is that, I've never seen such a greater outpouring of solidarity, really people kind of going to the extremes of human kind of performance and dedication, for their fellow colleagues, as well as, for patient care. The second thing I would say is that, people are burnt out and people are getting sick, and people are also worried. They're worried about being able to handle it. They're worried about getting personally sick. They're worried about getting their family sick. So it's a very kind of fraught and intense time for many people. I think that that's sort of a bit of the picture. On a slightly positive note, we've seen in New York the ICU admissions, the rate has declined. So we're starting to be able to discharge some patients, and also it looks like the rate of deaths has sort of plateaued. So that is not something that's kind of rising precipitously here in New York. I think that there will be different peaks at different times across the country, but at least for now, it looks like New York is maybe we can kind of see the other side, and so that's a little bit of hope.
No, you
in
said earlier
terms
that
of
140,000 beds. Is that you're saying the entire New York area has increased their capacity to 140,000 beds?
So that was the original goal of the state of New York, but it looks like we're downgrading the projections, fairly significantly, because it looks like we're hoping to be hitting the peak around now in New York, and so I think we have less than 20,000 people across the state that are admitted for COVID-19. So the worst projection, we're missing the worst projections by a fair amount.
Okay.
Yeah. So in terms of what I'm doing, I'm splitting my time between clinical care and also sort of policy advocacy and kind of supporting some of the infrastructure at the hospital. So on the clinical side, I'm still practicing as a gastroenterologist. So I cover one of our hospitals, and so people come in for other things as well, but then also people that have COVID-19 have GI concerns. So I've been seeing those patients, and in certain circumstances, needing to do procedures and things like that. So we've been learning a lot about the disease kind of in real time, assembling a lot of experience here. And then outside of that, the clinical kind of care work, I've also been kind of involved in some of the issues around identifying, how we can scale up mask supplies, how we can look at innovations, low-cost innovations around ventilators. So I've been thinking about those issues, and I've also been thinking about kind of macro level policy issues in terms of, how we should be responding as a country. How can we best be supporting our frontline health workers? So I'm thinking about those issues as well.
No, is there, like PPEs and stuff like that? They are all fine. I mean, for all the healthcare professionals, you're able to supply the PPEs and take care of their protection right now?
So, at my hospital right now, we have been okay. It's certainly not the same as it typically is. I mean, a lot of times the masks, are typically disposable masks. So, if you're, if you think the disease is generating aerosols, meaning that the viral particles are at least aerosolized in the close distance, then anything is soiled from the outside. So we, traditionally don't reuse those. So, we've started to have to, particularly for our N95 respirators, we've had to try to disinfect them, or we've had to cover them, and then we dispose of the covering and we keep the N95. So I've never, in my career in medicine, I've never done stuff like that, but we don't have enough. So, so that's one thing, but there are places that certainly probably don't have enough. I mean, I think, maybe you all have seen pictures of people using garbage bags and things, and so I think that's happened, and that's really sad and very tragic. But I think that that's hopefully getting better. I think that one of the things we're understanding about this whole crisis is a number of the sort of fault lines and things that just were not set up, and we had such concentrated supply chains. And when you have supply shocks and huge demand surge at the same time globally, and then you have a discoordinated procurement process where, states are, outbidding each other with the federal government, and then you have countries from all over the world, trying to, it becomes a very challenging process. And I think that we're all realizing that there has to be smarter ways to deal with supply and demand, when there's market failures. And so that's something I've been thinking a lot about. I hope that we come up with redundancy in our manufacturing and supply chains, after this. And
one of the questions that's posed here is that what's the main reason this widespread corona explosion in those areas? Is it, especially in New York, is it failure of social distancing, promiscuity, or any other special situation? Especially because US is such a sophisticated country in terms of compared to the rest of the world in terms of medical facilities and all those things. So it has been because there's a lot of movement of people from out of country coming in. What was the reason for it to explode like this in New York?
Yeah, I think there are really a couple of things. I think number one is that, New York is one of the most globally connected cities in the world. And so if, you have hundreds of, and literally thousands of flights in and out of Europe, as well as, Asia in some of the hard hit areas. And then you have high, population density in a small constrained landmass. I think that sets you up for, it's sort of a tinder box. I think the other thing is that, New York is a city of lots of young people that generally are healthy and like to be social. And, one of the things that we haven't seen before is such a highly transmissible disease in asymptomatic carriers. So, one of the reasons I think that we missed the boat on this is because a number of the previous viruses, if you look at SARS, that the mortality rate was about 10% in SARS. MERS, it was about 30%. And, Ebola is one of the most devastating, viruses. And so when you get the virus,
Ebola was what percent?
The mortality rate, I mean, it's extremely, extremely high. I don't know what the overall rate was. I imagine it was very different, if you were, in resource constrained areas like Western Africa versus, we had a number of imported cases, mostly in health workers. But I guess the point of that is that with these viruses, you were so sick, so you weren't really out spreading it around because you were too sick to be around. So with this virus, it's both highly transmissible and in healthy people, and so you have healthy vectors. So I think I think we didn't fully appreciate the asymptomatic carriage of the virus until the cat was out of the bag. And, after you have 3 weeks of unmitigated transmission with exponential growth curves, we were already well beyond containment.
So how many COVID cases are being added now in New York? You said the rate is coming down now, but what are you at right now? Because are you the highest now in the country, in the world right now? In terms
we are. I think we account for about 40 to 50% of the cases across the United States. The problem with the number of cases is that it's an artifact of testing, and so even though the numbers of cases will continue to rise, what I think and what a lot of epidemiologists look to be as sort of better data is looking at sort of things like ICU admissions and looking at the death rates, because the numbers of cases will just rise based on a function of testing. But actually, that's more of it's not disease transmission, because the transmission's already happened. It's just that now we have more tests. So a lot of us think that, the actual number of cases is anywhere from 5 to 20 times higher than the confirmed number of cases. So a
lot of people have not been tested.
That's right. That's right.
Right.
We're
Yeah.
testing a lot of people in New York, but on a per capita basis, the United States has maybe tested something like 2 million, but on a per capita basis, it's extremely low compared to all other OECD countries.
Yeah. And why do you think that's going to change?
Well, it has to. I think the only way that we can start to even think about opening back up is if we have a containment and mitigation strategy that involves testing and contact tracing and quarantine. And the only way we can do that is if we have massive testing at scale. So a lot of folks, think that we are magnitudes, below where we need to be in terms of testing. Most countries, their positivity rate is in the single-digit percentages. So, of the number of people they're testing, it's 1 to 2 to 3 to 4% positive. In the United States, our tests, our positivity rate is like 20-30%. So, we're just not testing
enough people.
Yeah,
that means
exactly.
Not testing enough people. Yeah. So our denominator needs to be much larger. So do you, since you work in the policy side also, do you see this changing? I mean, is there more investment being made to test a lot more people?
It sounds like it's a little bit hard to tell, to be honest. I mean, I think that one of the biggest problems from my perspective is that a lot of the messaging has been sort of clouded by politics. And, when you have a global scientific, crisis, you really need the facts, and you really need that from the scientific community. And it really can't be filtered by political parties. So I think that, I think that's one of the biggest tragedies of this, is just that, we've allowed politics to interfere with actually responding to the crisis. So, they say that we're scaling up testing, but, we don't really see it, to be honest. So I think that, we've used, some of the federal governmental powers. We have the Defense Production Act, where, the federal government can sort of request or implore the private sector to scale up production. So we've done that for certain things, including ventilators and PPE. So a lot of people think that we need to start doing that for testing. And the testing bottlenecks, it's not what people think. It's not that the machines are necessarily the bottlenecks. It's really the reagents, the solutions, the swabs. So it's kind of the inputs that are a lot of the bottlenecks there. So we have to really be thinking about that in terms of magnitudes of scale.
Right. So are you able to, I want to take permission from the viewers that we're going to go 5 minutes over, because I think we are on a very important thing. I want to conclude this properly. So do you see, Akash, that there's more of a medical intervention now? Is there more of a push to test more people in America, especially in places like New York, which is high density? I mean, California and all are like, there's widespread, right? So it's a little less, but in a place like New York, do you see, the medical community being able to push for more testing and things like that?
We're trying. I mean, the truth is that I think that we're witnessing the system not meet the needs. We're witnessing things just not working the way that we hoped. I mean, our leadership had said, now over a month ago, anybody that needs a test will get a test. And that's just simply not true. The way that we're doing testing right now is, if you're sick enough to go to the hospital, you potentially can get a test. So there's so many people that aren't getting testing here, and it's a big, it's a big issue, and I think there's lots of things to discuss, and a couple of the things I'll sort of mention is that there's some really interesting things around digital contact tracing. I know that you're very much into innovation, and Google and Apple, recently announced a project where they will hopefully be using kind of Bluetooth and kind of location services to be able to digitally trace contacts. So, when we potentially open up, you can imagine a system in which somebody tests positive and then you get an alert saying, you actually were in contact with somebody. This is all anonymous that tested positive. For the next 14 days, you should monitor your symptoms. If you feel sick, you should stay home. And then we're going to follow up with you every day. These are the sorts of things that we have to start thinking about. I think that, South Korea had this kind of radical digital transparency around contact tracing, which really served them well. So I think that we have to start thinking about those things differently.
But I do have to ask you, Akash, in that, is there a privacy concern? I mean, are we, and the thing is, when global health is concerned, we got to give up a lot of stuff on privacy as well. I get that. The question is, if you think of the regular world, regular cybersecurity and things like that, in situations, are we compromising on the privacy rules a little bit?
I think there's always going to be a tension there. I mean, I think the way that you think about it is that, even now it's opt-in. So, Google is asked, they ask you if you want to keep on location services. And I think for something like this, if it's a matter of personal and public health, I think most people will opt in, and I think that even if you get a critical, I don't know what the breaking point is, but even if you get 70% of people to opt in, I still think it would work. There must be a model that would say you need this amount of the population to buy in for this to work. And I think that a lot of smart people are working on that. So I'm eagerly following that.
Okay.
I'm eagerly.
Is there anything else you're following that's happening in another part of the world or something? Just to wrap up, that you feel would be really important today? Any other issue, any other aspect?
There's a number of drugs and things like that. We're starting to use convalescent serum here in the U.S., where we harvest the antibodies from folks that have recovered to basically use those antibodies as passive treatment. So that looks like the early data looks pretty good. There's a couple of drugs out of Japan that have been showing some interesting, mechanistic and also some interesting kind of early clinical data. Favipiravir and Camistat out of Japan. So we're kind of all eagerly following these drugs.
There are some vaccines being developed also right now, I think, right?
Yeah, so there's a clinical trial in Seattle for Moderna, and then a number of the big pharmaceutical companies. Johnson & Johnson has made a huge investment in vaccines. So I think we're all very, very hopeful, but in the meantime, we're just trying to all stay focused and strong and healthy. And I think just kind of in closing, I mean, the last thing I would say is that this also takes a tremendous personal toll. And, I think that a lot of this revolves also around kind of mental fitness and mental health and resilience. And, I just hope that we're all sort of supporting our, communities. And, they call it social distancing, but I think there's a movement now to call it physical distancing and social connectivity. So, how we can remain connected. So I really appreciate, connecting with you and sharing, with everybody. And so
it's great because it's been almost 6-7 months since we met, but it's really wonderful because of this we got connected to the medium. And so I want to say thank you and follow Akash Goel, who's been writing a lot about this, and he's also been working. So you'll get a lot of information by following him. And Thank you so much, Akash, for your time.
And thank you, Lakshmi. It's great to see you. I hope you stay healthy, and sending you my best.
Okay. Thank you.
Bye-bye.
Thank you, everyone.